And now we have Dr. Ray Kim to talk us about the treatment of special groups, that is, patients with decompensated cirrhosis pre or post liver transplantation, and also those with renal impairment, including those who are in hemodialysis, and non-liver transplanted patients, as well as patients with bleeding disorders. Ray, thank you very much, and once again, thank you for being here with us.
Thank you. We're down to home stretch. You'll be horrified to know that I have 3 talks. Now it's 12:23. I'm going to finish in about an hour.
Good.
Okay? So that's my goal. So the first talk that I'm going to give you is the complicated patients that I will summarize as liver transplant people, decompensated cirrhosis pre and post transplant, as well as renal. And then we have a case discussion. So if it's okay, I'll just go right into a case. Is it okay? And because my case is somewhat related to what I'm going to talk about, and then you can take over or let me finish or whatever. Okay. So this is the thing. So this is my minor case, not the other case that I'm going to talk about. So this is a 59-year-old person referred for liver cirrhosis. She had known about Hep C since 1998. She was tried on Hep C therapy, and then she developed pegylate interferon ribavirin, and she developed severe GI toxicity requiring hospitalization, and has had no interest trying any kind of Hep C treatment whatsoever. However, she now has ascites, and it has become refractory to diuretic treatment. She requires paracentesis every 2 weeks. Her CTP score is 10, MELD is 16. On ultrasound was done, there's no focal lesion. Should this patient be treated for hepatitis C now? Who says yes? Who says no? Who says only after listing for liver transplant? You can answer more than once. How about need more information? So I vote for 4. I mean, you can't hurt, right? So this is what we are talking about. Patients with hepatic decompensation, people whom we can't help. We can talk about hospice and whatnot, but the goal is to trying to lead these patients to long-term survival. And a lot of times, well, traditionally, liver transplantation was the only way to get there, right? However, this scheme is fraught with problems because of organ shortage. People on waiting list don't make it all the way to liver transplant always. And then even if you have liver transplant, you can have post-operative complications, and you can have problems of immunosuppression. So, and then one of the big complications, although not frequent, is fibrosing cholestatic hepatitis. So these patients have multiple barriers to get to the land with milk and honey. So introduce DAA. What can happen is you can improve the patient, and that patient can be delisted. If that doesn't happen, you can get into MELD purgatory. People talked about this. And then we can decide to treat that person after transplant, and then we have to talk about drug interaction, and then multiple things can happen like this. So how do we put this all together? So I asked for more information. She responds well to diuretic treatment. Bilirubin was 3.1, ALT of 68, platelets 68, hemoglobin, creatinine 1.4, and so forth. Her HCV RNA was 137,000, genotype was 1B. So if you decide to treat, what regimen should you use? Okay, good answer.
Well, I'll be very worried if you use an NS3. It's a patient that is already decompensated, and we should not use NS3s in those patients. So even the combination of grassoprovir will be potentially lecaprevir, you will have the same problem. The creatinine is 1.4, probably his creatinine clearance is above 30, so probably you can use sofosbuvir, velpatasvir, but it's very hard to select a very useful.
Not perfect.
Yeah, it's not
Okay.
perfect.
Even for supposedly it's borderline creatinine clearance is borderline for using regimes with sofosbuvir.
Right. So we'll talk about all of that.
I did a calculation of her EGFR, and she has 40 millimeters per minute. And so if she has 40, she can be a candidate for sofosbuvir ledipasvir or sofosbuvir velpatasvir.
The ultimate authority.
Well, no, not ultimate anything. I think this person has a MELD sodium of 20, and I think that ultimately the decision is about whether you can transplant a patient. I think that we can do a lot of permutations of what regimens to use, but this is a patient who is decompensated, right? Ascites, MELD is high. I think treating this patient is dangerous, and I think that you can avail yourself of transplantation. You can expand the donor pool by using hepatitis C positive donors, and so I think that option is one that the center should be thinking about. This should not be treated in the community without the availability of transplantation, because if you entertain treating this patient, 10 to 15% can decompensate and you have a sicker patient and you haven't cured the hep C. So you need to have them listed before you treat.
Okay, I don't need to give this talk anymore. That's the story. Okay, so things in this situation to consider ribavirin use or not. That's always tricky if we decide to treat. And then we also talked about renal function issue. Okay, so as was talked about already, the protease inhibitors should not be used in child B or C patients. So this patient would be at least child B. So we should be careful with protease inhibitor containing regimens, and there are some dose adjustment that needs to be made as a result of that. The ASLD guideline for decompensated hepatitis C cirrhosis for all genotypes, soft-val ribavirin for 12 weeks is treatment of choice for ribavirin acceptable patients. If ribavirin is not desired, then soft-val for 24 weeks is acceptable. Alternatives, soft-lead for appropriate genotype or soft-doc with ribavirin. That's what's in the guideline. Anything to add, Hugo? Okay. So let's look at some of the data. So this is a soft-val data, so-called Estrel-4 data. So this is a study design. Soft-val for 12 weeks with ribavirin for 12 weeks and soft-val combined for 24 weeks. This is an open label, randomized 1:1 US study. All genotypes, treatment naive or experienced with CTPB cirrhosis. And there's a renal function criteria, reasonable platelet count, no HTC or liver transplant. Here, the ribavirin dosing was based on weight. So pretty hefty doses of ribavirin. And this was the bottom line for genotype 1, 2, 4, and 6. If you compare the three bars, the best bars is the one with ribavirin for 12 weeks. And that's what the guideline is based on. As a frame of reference, this is Astra-4 data with the similar genotypes. With soft-val without ribavirin for 12 weeks, we can achieve roughly similar response rate by adding ribavirin in this difficult to treat patients. How about genotype 3? This is the difficult to treat patients these days. Here, Astra-4 is 85, but the confidence interval is pretty wide because of number of patients. Astral-3 data, there are different permutations of patient types. So treatment naive and experienced cirrhotic patients had 89 to 93% without decompensation. These patients, there is a little bit decrease in responses once they have decompensated. So although this combination makes up for the difference, which was used to be difficult to treat as a result of decompensation, genotype 3 remains a little bit challenging with this newest regimen. One thing to remind everyone is when you look at the CTP score of the patients, they are very, mostly 5, 6, 7 is Charles A, 8 and 9 are B, so they are almost that. There were very few people who are CTP 10 or higher. So severely hepatically decompensated patients, we have very little data to tell us what the response rate is, and even more importantly, what will happen to them in terms of their hepatic function. So think about that. So in terms of that, this is the MEL score change. Patients with less than MEL of 15, sort of half the patients got better with their MEL score. About a quarter actually got worse, as Hugo just said, and about a quarter remained the same. Patients who had higher MEL score, however, had more to recover, and fewer patients who got actually worse. I think part of this is a little bit of a regression to norm kind of a thing, but this does tell us that people with a bit not super high MEL score, but people on the higher range of 20 or so, we should not necessarily be discouraged from using treatment because these patients do recover to some degree. I'm going to just brag about my abstract that just got accepted for EASL, where we compare the expected and observed mortality of patients who participated in SOLAR and Astral data. So this is what their survival would have been based on their MEL score. A number of deaths would have been based on the MEL score, other patient characteristics, and these are the number of deaths observed in their trial data combined, showing that as the time goes by, there are fewer and fewer deaths that are occurring. That's much smaller than that was expected. At the end of the year, the SMR, which is the sort of a ratio of mortality, was only 0.44, meaning that over 50% of the patients were saved by being treated for their hepatitis C. This is reflected in the waiting list registration data. So this, we looked at the overall waitlist registration for the interferon era, the first generation PI era, and the DAA era. And red is hepatitis C, which is by far the most common. Now we're seeing a reduction in the waiting list, and that is more exaggerated in patients with hepatic decompensation, and HTC much less so. But the trend is encouraging that fewer and fewer patients are coming to transplantation for hepatitis C. As a side note, this is not all DAA. A part of this is the baby boomer people getting too old to be considered for transplantation. I don't know if it makes sense. So a lot of this is treatment being more effective, but waitlist registration requires the person to be healthy, and hep C patients who are older and being eligible to transplant is becoming fewer. And this is a data that we looked at SRTR as to how many people actually are taken off the list because they were treated. So we merged the waitlist data with pharmacy claims data and figured out who went on treatment. And this is people who received sofosbuvir. The instance of waitlist removal because of their condition got better was significantly higher than patients who did not receive sofosbuvir-based therapy. So the difference became significant after about a year. So MEL purgatory. It's really hard to predict who is going to improve, and therefore we should treat, whereas people who will fall into MEL purgatory, their hep C is gone, but their symptoms don't improve, and their MEL doesn't progress to make them eligible for transplant. And this was a recent modeling study where they looked at which strategy is preferred. Should we do pre-transplant hep C treatment or post-transplant hep C treatment? So if the black bar is higher than the gray bar, that's a situation where pre-transplant would make more sense, whereas if they're equivalent, then they are about the same. And in their calculation, that the difference became a bit more reasonable at around a MELD score of 27, meaning that if you have a MELD of 27 or higher, you definitely need to wait until transplant before you treat. If you have a patient's MELD less than 27, then maybe there's a chance that the patient will not need transplant and be able to be removed from the list. But a lot of this depends on how available your liver is, obviously. So if you have our region transplants in the high MELD of high 30s, so oftentimes it becomes very, very challenging to deal with patients' high MELD score who's far from being transplanted and they're suffering for decompensation symptoms. Do we pull the trigger and treat those patients and take a chance that they will improve and not require a transplant or not? So my rule of thumb is to ask the patient, if your symptoms are like this today, and suppose that you get treated for hepatitis C, and you will be like this for the rest of your life, is that acceptable compared to the risk of waiting and going on to transplant? And some patients, yeah, I have some ascites and I'm fatigued, but I'll do okay, I'll deal with it, then we treat. But other patients, I hate the way I live, it's not worth living, I'll take the chance. If I don't improve, I'll live with it, then we go on to transplant. Does that make sense? Yeah. So no modeling can answer that. So pre-transplant hep C care, avoid protease inhibitor. It limits selection of DAA, as we just discussed. Still need ribavirin in this population. Good SVR is expected. However, it may be lower than compensated cirrhosis. Severe hepatic decompensation, Child-Pugh-C, has not been well studied. So when you deal with those patients, be careful. AE profile is pretty good. Ribavirin toxicity is still significant, but manageable. SVR may improve liver function, decreases the need for transplant, waitlist deregistration we talked about. MELD purgatory, you need to individualize the approach. So this patient, as you eloquently pointed out, that she chose not to be treated, and then she hoped that she would undergo liver transplant soon enough and then would receive DAA treatment afterwards. So what precautions should you take in managing this patient after transplantation? Acute cellular rejection is a concern. Fibrosing cholestatic hepatitis is a concern. DAA interaction with immunosuppressants. SVR rates due to DAA, all of the above. What are some of the things that you think about as these patients? It's a gimme, right? It's all of the above. All of the above. So I just wanted to point out acute cellular rejection. This is not such a big problem anymore, but do you remember the time when we used to be very confused? Is this rejection or is this recurrent hep C? And we would go back and forth, and we take missteps. Still happens sometimes. It's not that straightforward. And pathologists are experienced in differentiating those two. Some of them have retired, and we have new generation pathologists that may be not so helpful. We'll talk about fibrosing cholestatic hepatitis, and SVR rates with DAA, we will talk about all of this. So going back to ASLD guideline, liver transplant recipients, patients who have no cirrhosis, liver transplant, no cirrhosis, genotypes 1, 4, 5, 6, treatment choice is GLP-1 for 12 weeks or soft-lead and ribavirin for 12 weeks. Genotypes 2 and 3, GLP-1 again for 12 weeks or soft-DAC ribavirin for 12 weeks. If you have a compensated cirrhosis, the guideline says soft-lead ribavirin. It deletes GLP-1 as a preferred not because it is not expected to work, but because of positive data. So as an alternate, they do suggest that. And 2 and 3 soft-act ribavirin. Decompensated, it becomes a bit more like the other story, soft-act ribavirin, or for genotype 2 and 3, soft-act ribavirin, soft-vel ribavirin are the choices. So you can look this up in the guidance website. We talked about the drug interaction. This is also from the guideline. There are 3 red boxes for you to be careful about. Elbasvir and grazoprevir combination with cyclosporin. Combination is not recommended because of drug interaction. Glipip combination in cyclosporin, not recommended. A triple regimen with cyclosporin, not recommended as well. I don't think this is absolute contraindication you can manage because you can monitor the drug levels, but just be aware that there's a pretty significant drug interaction between DAAs and immunosuppressants. Fibrosing cholestatic hepatitis C is the most aggressive form of post-liver transplant recurrent hepatitis C. Have you seen these cases? It's really scary, isn't it? It's horrible. Most horrible patients to take care of. It's amazing how the liver just crumbles and just does poorly, and it has the very, very high levels of HCV RNA. In the SOLAR study, they specifically studied these patients, small numbers. 7 patients received 12 weeks of triple combination, and 4 patients had 24 weeks of that lead-soft and ribavirin combination. What's impressive is 100% responded, as you know, and the encouraging part is their liver function improved, and they all got better. So everybody survived. So FCH used to be the worst thing, but now we can deal with that successfully. So in summary, patients with liver transplant candidate with chronic hepatitis C, Child-Pugh A, or MELD exception points, so that basically you have a compensated liver function, then you treat that person pre-transplant, clinical stabilization and prevention of recurrence. You can use almost anything for the compensated patients. For decompensated cirrhosis, Child-Pugh B or C, if the MELD is still relatively low, and even better if you have a live donor transplant, then you should go ahead and treat that person in the hopes that the person will improve and transplant would be not necessary, or you should go into live donor transplant if things don't work out. Patients with high MELD score, MELD 27, this is somewhat based on the decision analysis that we shared, or have lower GFR, these patients should go to transplant without waiting for a DAA pre-transplant, and then the middle patients, the treatment should be individualized. Okay, renal disease. The DAAs have gotten so far very, very good, and this is a guideline, CKD stage 1 to 3. Basically, any regimen is okay. The guideline omitted the 3D regimen. Hugo, can I ask you why it was removed?
Because we felt that it wasn't going to be used very much. It hasn't inserted itself in the market, and this is so much easier with a lot of really good data. So, I think that we're having to get rid of regimens that people aren't using.
Right.
So that's the only reason that you can't use it. Yeah.
So it's not necessarily wrong, and
It's more drugs. I mean, the renal burden's higher.
right.
However, let's just say that in countries like Mexico, that's available. Well, GP is not available. So I think that this is something to be considered for certain parts of the world.
Yeah, that's why I asked.
Unfortunately, the disclaimer is that we are actually creating a guideline for the U.S. primarily, for the U.S. market. So, and we recognize that's a concern, and that's one of the reasons we hang on to a lot of these regimens that just don't have market penetration. And we just at some point we have to say, well, even the companies aren't promoting them anymore, so at some point we have to stop.
It's also true that the treatment regimen was in the process to be almost discontinued by the old pharmaceutical companies. So as Hugo said, I mean, they were on the way to just not having it in the market. So there was no option.
It's a good problem to have, and apologies for those of you who don't have all the drugs that we have. But I think we keep them as potential uses, and if you really dig into what we have, they are available there. It's just they're not featured predominantly.
So convenient to have you, Hugo. So convenient to have you. All the discussion that's needed to be done. So for CKD stage 4 and 5, mainly GFR less than 30, GP is preferred, all genotypes, for 8 to 16 weeks depending on their treatment experience and cirrhosis. And then the Merck regimen, genotypes 1 and 4, they can be treated for 12 weeks. Kidney transplant recipients, 1 or 4 here, GLP for 12 weeks or soft lead for 12 weeks. 2, 3, 4, 5, 6, same thing for the first choice, and soft ribavirin for 12 weeks. So that's, you can look this up for the guidance. So should I go on?
Yes, I guess so.
Yeah, so we had enough, any burning questions at this point? Okay, so can we go on to the next? So go ahead.
Sorry. Do you have a protocol to decide when to start the therapy after liver transplant?
Sure. So the question is, when do you start DAA therapy after liver transplantation? So in the old days, when we had to use interferon, we had to wait until patient was really, really stable, right? And then we could use the treatment. Now we're getting more and more close to transplant. I think that most people implement DAA therapy about 6 months after transplant, but we tend to be more aggressive. So if the patient is stable, surgically stable, no medical issues, and immunosuppression is settled, and there's no dose adjustment need to be made, you can start treatment even before 6. But most people will pick 6 months as the sort of a sweet time point to do DAA treatment. So, case, I picked a case.